Okay, welcome back to today's webinar. This is meant as an introduction to low-level laser therapy or photobiomodulation, that's the new research term for this type of therapy. Really what I'm trying to do with this webinar is provide some science and some research and some understanding. It's really not about our equipment per se at all. So it's more just so you guys can understand exactly what this is all about, how it might help your patients, and why I personally think that it's something that you should always have in your toolbox as a clinician, whether you're a chiropractor like myself or another type of clinician, just because of what it can actually do to the cells and the tissues as well too. Okay, I have tons of slides to get through, so hopefully I'll get through all of them. Remember, you can ask questions at any given time, just type them in. My preference is you type in your questions as we go along so that you don't, so that I can get to them at the very end as well too. Okay, all right, so again, I want to thank everyone for joining me today. I really appreciate you taking the time to do that. So let's get started. So we're going to talk a bit about the history of this laser therapy, sort of where it came from. The origins are really interesting, and I think it's important that everyone understands that. Then I'll go right into the definition of laser therapy or photobiomodulation. Then everyone's favorite topic, I'll talk about the fundamentals of the physics of light and tissues and how that's really important in order to achieve really good clinical success. A lot of clinicians that I've spoken to over the years, they dismiss laser therapy. They may have tried it, even bought equipment, and the results sometimes weren't there. And to be honest, a lot of that has to do with they weren't either trained properly, or they didn't really know what they were doing, or the equipment may have been inadequate. So this isn't something that you learn overnight. This is something that you need to understand the fundamentals of it and how to use your equipment, whatever equipment you have, and how to best approach every patient. So it's really a lot to it. It's and you should constantly read and understand about it, because your results will be that much better. I'll talk a bit about physiological reactions of light with the cells and the tissues. And then lastly, I end up with talking about the parameters, a pulsing of light, how it provides pain relief, something called the biphasic dose response, which is really important to understand how laser therapy works. And then, of course, we'll have time for questions and answers. All right, so let's just move on here. Really, when we talk about light therapy, it really goes back to thousands and thousands of years ago, when the use of natural sunlight was used to help patients or people that had injuries or diseases. And this is called heliotherapy. And it dates back, as far as documented, back to 1400 BC. And of course, they weren't really sure what was going on, why the light helped, but it was certainly indicative that light could help wounds heal faster. Light could help certain skin diseases or irritations and so forth. Now, really, it wasn't until Dr. Niels Finsen, who is a medical doctor, he's from the Faroe Islands. Faroe Islands are in between Denmark and Iceland, so it's a group of islands way out in I guess it's the North Atlantic Ocean. And he pioneered the use of what's referred to as phototherapy. This is in the early 1900s. Now, he actually won the Nobel Prize in Medicine and Physiology for his work. This was right around when the first incandescent light bulbs and artificial light was being manufactured. He was able to use filters to provide narrow bands of wavelength. Specifically, he found in his research that red and ultraviolet had an interesting effect on metabolism and on pathogens. So he started to treat different prevalent diseases at that time in history, including smallpox, skin tuberculosis, and measles, with really good results, obviously, because he won the Nobel Prize in 1903. Unfortunately, he died prematurely. He had something called Pick's disease, And this is actually part of the reason why he got involved in phototherapy. So really this portrait of him was right around the time that he died. You can see he actually looks kind of sickly. So he's really the pioneer of artificial use of light. That's phototherapy. Now, his work really wasn't carried on. There was no one to carry on his work. But one Swiss physician, Auguste Rollier, he was inspired by Finson's work, and he actually started to use more heliotherapy, especially for tuberculosis. And he had a sanatoriums built high up in the Swiss Alps, and he used specific dosaging of natural sunlight, not only for tuberculosis, although that was the most prevalent use of it, but also skin lesions and wound care, that kind of thing. So he was actually really well respected in the I think in the 1920s and 30s, that kind of thing. And what happened was, of course, as soon as they discovered antibiotics and were able to treat tuberculosis with that, his work kind of fell out of favor, although he certainly initiated the use of phototherapy even more, heliotherapy in this case. Then in the 1960s, it was really interesting. There was an article published. This is a Canadian link to laser therapy, which I think is pretty cool, published by Paul McGuff, and some other medical doctors. And he used a laser, which at the time, 1964, were first being introduced for laser surgery and so forth. But he used it specifically to treat experimental malignant tumors in hamsters, and it was published in the Journal of Canadian Medical Association. He was from Boston, Massachusetts. So his work, what he did was he injected malignant melanoma in the pouches of the cheek pouches of hamsters. So there you can see the melanoma. It's a growth, and then he used a laser to actually eradicate and completely cure the hamster of the malignancy, right? Now, these were higher powered lasers, but this was the first use of lasers in medicine, specifically for removing tumors, right? So it's quite interesting. Now, this gentleman, Professor Andrei Mester in Hungary, around the same time frame, a few years later, read McGuff's paper and wanted to replicate his experimental work. So he injected tumor cells in the shaved bellies of rats, and he treated it with what he thought was a similar laser used by McGuff, made at the University of Budapest. Unfortunately, fortunately actually, his laser was calibrated much lower than the one used by McGuff. So the effect overall was nothing on the malignancy, but the hair grew back faster compared to the control. Based on that serendipitous discovery, Mester went on to see what kind of effect this low-powered laser would have on wounds. So he did skin flap wounds. On the left is a control, and on the right, in the circled area, was the wound that was treated with this low-calibrated red laser. And it appears, it's quite obvious, that the wound in the same time frame compared to the control was healing much quicker. Now, what's really interesting is if you look at the adjacent wound that was not treated with the red laser, but you can see it's healing faster as well compared to the control. So Mester discovered not only that red wavelengths of a certain power helped wounds heal faster, he also noticed there was a systemic effect. And this systemic effect is really, really important when you're talking about photobiomodulation or laser therapy, because it stimulates white blood cells and immunomodulates the area that's inflamed and injured. So it has an additive effect than just treating directly with the laser itself. So the definition of photobiomodulation is in fact, it's a form of light therapy that uses non-ionizing forms of light, including, but not necessarily, lasers, LEDs, broadband light, and so forth. Generally speaking, the power output of each diode needs to be under 500 milliwatts, otherwise it's a thermal effect. So we want a non-thermal or no heat being produced. And this light's absorbed by photoacceptors called endogenous chromophores. And when they're excited, they cause a photochemical reaction similar to photosynthesis. And this can be beneficial to the cell. Including reducing inflammation, reducing pain, modulating the white blood cells, and so forth. Now, when we look at the spectrum of light and what it can do, this is just a neat little chart that shows you the wavelength, the increasing wavelength, and the dosaging or the power, right? So if you look at the very bottom, you have ultraviolet light, which has a wavelength around 300 plus nanometers. And then you get into the visible wavelength, approximately 500 nanometers or so in the violet and blue spectrum and green. And then you get into the red and near infrared and enough dosaging to cause photobiomodulation. That's what PBM. So therapeutic wise, there's sort of a cutoff area in this region. Now, as you increase the dosaging, you can see it becomes destructive. So the amount of energy will actually cause a heating effect, and this is what we refer to as surgical photodynamic therapy or surgical laser therapy and or photodynamic therapy. So this is different than the lower dosages and different wavelengths. Now, the theory goes that back in the turn of the 20th century, Albert Einstein, of course, came up with the fundamental quantum theory. And based on that, Theodore Maiman built the first working laser in the 1960s. And around the same time frame, Nick Holonyak also discovered and built the first working LED. So these are the important scientists that led to the use of lasers and LEDs for photobiomodulation. Now, these first working lasers, as I mentioned, they tend to be higher powered, and they were used by surgeons to actually cut and ablate tissues, similar to that hamster research I mentioned earlier. When you look at a high-powered laser and how it affects tissues, well, of course, it hits like a bullseye, and it's high-powered, so it will carbonize and vaporize and coagulate protein. But as you get farther away from where that light directly hits the tissue, the amount of energy decreases, and eventually you'll get to a zone of photoactivation where there's lots of light but limited temperature increase, and that's what we refer to as low-level laser therapy or photobiomodulation, whereas the heat is referred to as high-level laser therapy and more of a surgical tool. So what is a laser? Well, laser, you may recall, stands for light amplification by stimulated emission of radiation. That's the acronym. Really what it is, the early lasers used a red ruby crystal rod. So that's what this red sort of bar represents. And wrapped around it was a high-powered fluorescent pulsed light tubing connected to a high-voltage generator. That's number one. So when you pulse out the light that's wrapped around the ruby crystal, the photons emanating or emitting from these fluorescent tubing will send photons that are immediately absorbed by some of the atoms in the ruby crystal. That causes the electron orbit to increase. And what happens is this electron orbit, this high orbit, will spontaneously go back to its original position, shooting out a photon of light. This photon of light then can interact with a similar atom that has a high level electron orbiting in it. So it's already stimulated, and that can now stimulate that atom to shoot out not just one, but two atoms. So that's stimulated emission. So when it sets up a chain reaction inside a tube with mirrors and a little hole, and this chain reaction will start to release all these photons as it's spontaneously emitting with zigzagging and going through all these atoms of the ruby crystal. So that's essentially what a laser diode is. Lasers are classified according to the power and the eye injury hazard. Anywhere from very low class 2, 0 to 1 milliwatts, all the way up to class 4, which is plus 500 milliwatts of power. Nearly all lasers used in low-level laser therapy or photobiomodulation are class 3B. The reason for that is class 3B provide enough energy to cause a therapeutic effect, but not too much light to cause a heating effect, and not too little light to cause no effect. So generally speaking, if you're going to use a single laser diode or one or two laser diodes, it should be in that class 3B. If it's class 4, well, you're not dealing with photobiomodulation. I do want to emphasize here to everyone listening that are clinicians, especially if you're looking at getting a laser therapeutic device, class 4 laser therapy is not class 3B, obviously, or photobiomodulation. Class 4 laser therapy works on a different fundamental basis, and it's not photobiomodulation. I don't have the time to get into that, but unfortunately, a lot of class 4 manufacturers lump themselves in with class 3B and photobiomodulation, but all the research is on the class 3B output of power, or LEDs if you have enough of them. So it's important to understand that you don't have to use lasers, but you need to have enough appropriate wavelength to treat for long enough, depending on what you're using, whether it's LEDs or laser, and most importantly, the dosaging. So if these are all correct, then or at least in the proper dosaging parameters, you will have a positive effect. Now, an LED is a little bit different than a laser diode. Obviously, there's negatively and positively charged layers, and they interact at a PN junction, and where they interact, when you provide electricity, it causes photons to be emitted in a narrow band, but not like a laser, so it's not coherent light, it's incoherent light. LEDs are getting much better, and you can make them a lot more powerful, but of course lasers you can make extremely powerful, which we all know. So really the major difference between LED and lasers is lasers are coherent beams, and you can make them very powerful. They're all one specific wavelength, whereas LEDs are incoherent light. They tend to be a narrow band of light, so in a range of nanometers, coming out incoherently and with less power. When we talk about the electromagnetic spectrum with respect to laser therapy, it's important to understand that anything shorter than the visible spectrum around the violet range turns into ultraviolet. And you can see the shorter the wavelength, the more energy. So once you get into ultraviolet, X-rays, and gamma rays, this is considered ionizing radiation with enough energy to break covalent bonds and potentially leading to cancer. So, think about ultraviolet and overexposure to sun can lead to skin cancer, for example. Whereas the visible spectrum, and as you get longer wavelengths, less energy, considered non-ionizing radiation and is not mutagenic. And of course, when we talk about laser therapy, we're referring to the visible spectrum and the near visible spectrum, or infrared. So how does this photobiomodulation therapy work? Well, essentially, first we need to understand that for a photochemical reaction to take place, light has to be absorbed by some type of photoacceptor. That's the first law of photochemistry. So examples of photochemical reactions everyone's familiar with is photosynthesis, the formation of vitamin D by exposure to sunlight, bioluminescence, think about fireflies. Of course, in your eyes, there's a photochemical reaction between light and rhodopsin, a photoacceptor in your retina. So those are all examples that I'm sure we're familiar with. Now, when it comes to photobiomodulation, the chromophore or photoacceptor that we're most interested in is not obviously chlorophyll like in plants, or rhodopsin in the retina, or melanin in the skin, or the blood, hemoglobin. We're interested in specifically cytochrome C oxidase in mitochondria. So that's the target photoacceptor, not myoglobin or melanin or rhodopsin. The reason for that is cytochrome C oxidase, if you look at the inside of a cell in the mitochondria, specifically the inner membrane of the mitochondria, if we look at it, of course everyone recalls that this has the electron transport chain, and the one of the terminal enzymes is cytochrome C oxidase, or CCO. And the very terminal enzyme is ATP synthase. So this is aerobic respiration, where normally what happens is you have the proton gradient pump. This causes the energy to be transferred back to ADP into ATP and the formation of energy. So this requires glucose, a Krebs cycle, oxygen, and of course that's how we get energy into our cells. Now what's really fascinating is how photobiomodulation works on this photochemical event. So on the left is a schematic diagram of cytochrome C oxidase. And what happens is when you have inflammation or an injury process, you have an increase in intracellular nitric oxide. As this peaks and becomes too high, it preferentially binds to copper, which is Cu, and heme subunits within the cytochrome C oxidase enzyme. That prevents or blocks oxygen from binding and thereby inhibits metabolism and the production of ATP. As ATP levels decline in cells, they start to spiral out of control, and it can trigger cellular apoptosis or death, right? So we don't want this. And so what do? Well, we try to speed up the healing process in different ways, whether it's helping with, mechanically manipulation, acupuncture, all these different things. How laser therapy works is the light energy, specifically from certain wavelengths in red and near infrared, has enough energy to break the hydrogen bond between nitric oxide and copper and heme. By doing this, it causes the dissociation or photodissociation of nitric oxide. And what happens is the nitric oxide is free to diffuse through the membrane, allowing oxygen to bind back on, and therefore increasing the respiration rate and the ATP production, allowing the cell to start to increase its metabolism, increase the mitotic index, and start to have regeneration and repair of damaged cells and tissues. So think of it as a boost of energy by illuminating these cells with light. So it has other interesting reactions as well. This light, as I mentioned, can directly interact with cytochrome C oxidase, producing more ATP, releasing nitric oxide, which in itself can cause vasodilation. And ATP, of course, increases the efficiency of the sodium-potassium channel. There's a short spike of ROS, which is reactive oxygen species. And this ROS would trigger an enzyme called nuclear factor kappa beta that triggers the transcription of proteins that cause cytoprotective effects on the cell. So it protects the cell from further damage. A light can also be absorbed directly by calcium ion channels and increase the influx of calcium into the cell. So it's all these different reactions going on is how photobiomodulation works. Now, when we talk about photobiomodulation, we're really referring to very specific a band of wavelengths, specifically in the 600 to 900, 1,000 nanometers of range length. Anything sort of shorter than that, as you get to ultraviolet and X-rays and gamma rays, well, of course, these have too much energy and can be potentially damaging. So it's really a very short window of wavelengths that can be effective. And even in these wavelengths, you have to be really careful because some are effective and some are not. We're not using mid or far infrared. That's important to understand because I oftentimes get questions about using infrared therapy, like infrared lamps or infrared saunas. They use wavelengths over 1,000 nanometers because it targets water. It can have a therapeutic effect, but it's not the same type of photochemical reaction that I've been referring to. Now, when I talked about the specific wavelengths, a lot of the research was done by Tina Karu. Tina Karu is a Russian scientist out of Moscow, and she did a lot of interesting research and determined that very specific wavelengths, 620, 680, in the 600 range, 760, 820, around those ranges, are what are absorbed best by copper specifically. So these wavelengths, or around these wavelengths, plus or minus 10, 20 nanometers, will be more effective in stimulating cytochrome C oxidase. And that's why it's really important to understand that you're not using a device that doesn't have the ranges of appropriate wavelengths that science and research has shown to be most effective. And this is really important when you're choosing a laser therapy device. So Tina Carew and other of her colleagues have determined that these specific ranges seem to be most effective, not only effective, but certainly the most effective wavelengths. So there's a window, a therapeutic window, roughly 630 to 900. You can stretch it out a little bit, but it's going to be in this range. Anything below 630 is absorbed by hemoglobin. Anything above 1,000 to 900 is absorbed by water. And of course, melanin also absorbs light. It does absorb a fair amount of red light, so red light does not penetrate very deeply because of melanin. But you see it drops off around 750, so right around 780 to 830, 840 nanometers can get through melanin and deeper into the tissues. That's why you tend to see near-infrared wavelengths used a lot as well. So therapeutically, you will see red and near-infrared. Red light can penetrate several millimeters, maybe 5-10 millimeters. Whereas near-infrared can go a little bit deeper. 10 millimeters, that's 1 centimeter, and a little bit deeper, maybe 20, 30 centimeters, depending. Don't listen to any manufacturers that claim they have insane amount of depth of penetration. That's all BS. It really depends on different factors. That is the density of tissue, the amount of blood, the amount of melanin. There's all these different factors at play. But if you can push the laser probe into the tissue, you can actually get your light even deeper because you displace not only blood, but the tissue. So theoretically, you can get light 3, 4, 5, 6 centimeters deep into the human body if you know what you're doing. But if it's just gently resting on the surface of the skin, you're not going to go 6, 8, 10 centimeters in the body. It's impossible. However, the longer that you hold the light, the greater the effective depth of penetration depending on the wavelength. So sometimes longer periods of treatment time will help you get greater dosages to the maximum depth of penetration. Okay, so now what are the physiological effects of laser therapy? Well, it has interesting effects on angiogenesis and neovascularization and vasodilation. This allows for increased blood flow. It can increase collagen production and help with wound healing and healing in general. It can have an effect on skeletal muscle fibers and increase their ability to repair. So if you've strained a muscle and add light therapy, you'll actually see an increase in or a decrease in the time to heal because it stimulates myosatellite cells. It can have an effect on white blood cells to increase anti-inflammatory mediators and decrease pro-inflammatory mediators. It can vasodilate to decrease edema. And it can have a profound effect on repairing nerves, cartilage, and bone. I'll talk about all of these in isolation. So with respect to angiogenesis, what's interesting is there are increased fibroblast growth factors that occur with laser therapy, as well as platelet-derived growth factors. This type of stimulus will actually cause the ability of these vessels to grow. If you withdraw or decrease these factors, then of course you'll see regression of new blood formation. So it's well known that photobiomodulation can actually increase these factors. So I'll give you a couple examples. On the left is a patient that presented with a gangrene secondary to diabetes, ulcerations. So what happened here was you can see there's bone sticking out. Her toes are on the verge of going gangrenous as well, the smaller toes, and she was scheduled for amputation. Now, this is one of our patients. Over months, we were able to help improve angiogenesis and microcirculation in her foot, and eventually we were able to get complete regrowth of that gangrenous area. So, you know, this is a direct example of how you can see growth of tissues if you provide it with appropriate circulation. Another one is post-surgical, where you see treatment over a progression of time. And what's really interesting to note, I want everyone to take a look, is you see the scar tissue formation is minimal. The reason for that is that not only does photobiomodulation increase collagen production, but it increases the maturation and repair of collagen and fibroblasts. So you're actually not going to leave a lot of immature collagen left. You're going to actually get it to mature into type 1 collagen, and that's less observable keloid formation. So normal collagen, say in a normal ligament, it's about 95% type 1 collagen. When you tear a ligament or you tear into tissue, the remodeling is such that you'll start to get a lot of type 3 or immature collagen. It tends to be disorganized and not in the parallel sort of alignment that you would expect with normal, say, ligamentous tissue. We know that laser therapy can actually decrease the accumulation of type 3 collagen, and this helps improve tensile strength of the repaired ligament. It can increase the thickness of collagen fibrils and decreases remodeling time, and therefore accelerating the healing process. So overall, this will help with collagen organization. So of course, why is this important clinically? Well, we tend to see as clinicians a lot of injuries like a torn supraspinatus tendon, for example, right? Or an Achilles tendon tear as well. So anything we can do to help promote healing of collagen, of course, that's what we're going to try and do. Now, unfortunately, this is important clinically because oftentimes our patients are coming in and they've had incomplete healing because, of course, they just think it's going to heal on its own. And depending on their age and their activity level, may end up with chronic tendinosis in the degenerative state of their tendon. So a tendinosis kind of scenario. So the idea here is that you stimulate with light therapy to help restore the normal functioning of the tenocytes, which are fibroblasts, to help repair this chronic scenario in tendons. When it comes to skeletal muscle repair, recall that when you injure or tear skeletal muscle fibers, you have quiescent myosatellite cells, those are the green blobs, that are stimulated to undergo mitosis and then repair and or turn into new skeletal muscle fibers. That's the normal process. Now, there's been a lot of in vitro and in vivo studies that have confirmed laser therapy can help regenerate muscle tissue through the activation of these satellite cells. One specific example I can give is they compared the skeletal muscle fibers in mice, and some of which were irradiated with red laser light. And then when they examined the number of satellite cells per fiber, they found that there was actually about 5 times as many active myosatellite cells compared to the control. So the more active stem cells, obviously, the better the repair of the torn muscle fiber. Another interesting effect is that on inflammation. So normally when we have inflammation, we have capillary widening, increased permeability, and then you get influx of white blood cells. You might get migration of white blood cells into the area. You'll get heat and redness and tenderness and swelling. Everyone knows the cardinal signs of inflammation. So what does laser therapy or photobiomodulation do to affect inflammation? Well, it has an effect on white blood cells. There's been a significant amount of research to show that you increase macrophage activity and the numbers of macrophages by exposing the tissue area to light. Macrophages will decrease the number of active neutrophils and sort of get rid of them, and this helps to break up the cycle of chronic inflammation, because chronic inflammation is usually due to prolonged neutrophil influx. The other thing that light therapy does is it decreases oxidative stress, and it promotes cell survival and reduces overall cellular damage. Further anti-inflammatory effects include the increased secretion by white blood cells of anti-inflammatory cytokines, and in turn the reduction of pro-inflammatory cytokines or mediators. By reducing and or increasing these cytokines, it has a profound effect of reducing the inflammatory process in these tissues that allows for increased repair of the tissue involved. It can also help to reduce prostaglandins. Now, prostaglandins are secreted, and it tells the body that there's an injury there by irritating pain fibers. So if you decrease prostaglandin levels, you'll reduce pain. So that's also a really important way of reducing pain with these patients. By the way, if you're finding this a lot of information over a short period of time, I hear you. So if you're interested in sort of having a prolonged introduction and training, at the end of this webinar, I'll talk about the dates for my upcoming full one-day trainings online. So how does photobiomodulation affect nerve regeneration? So for example, compressed nerves at the spinal level or extremities, these are all the types of conditions as a chiropractor or another clinician that you'll come across. A lot of the research has shown that low power laser irradiation, when applied to peripheral nerve, can prevent a drop in action potential, and of course that's going to help with the ability of these nerve cells to function. It also reduces scar tissue formation, and I've mentioned that earlier. It also increases vascularization, which I mentioned earlier. And it mitigates the degeneration of surrounding muscle tissue because you're increasing the action potential. And lastly, it's going to accelerate the regeneration of the injured nerve itself. So this particular paper showed an intact nerve. So you can see here are the axons and the sort of the way it looks like a normal, healthy, intact nerve. This is a intact nerve, a sciatic nerve that was crushed, and then after a period of time, you can see what happens is in this crushed area, you have an increase in mononuclear cells, which are white blood cells. And you also observe myelin degeneration, which are the little tiny asterisks you can see here. So let me back up. Normal, crushed. Okay, one more time. Normal, and then crushed. All right? So now, let's, so what they did in this particular experiment, they didn't expose the crushed sciatic nerve, to laser irradiation over a period of 7 days. So this is what you see here. So you start to see less influx, and you start to see some more normalcy of the axons. And then after 21 days, you can see that there's even a greater repair going on. And the way if you compare that to the very beginning, you can see that it's starting to look more and more normal. So the findings of this research specifically showed that the lasers had a biostimulatory effect such that it initiated the proliferation of astrocytes and oligodendrocytes in the nerve cell. It reduced oxidative stress, which of course can lead to excessive fibrosing. And it increased the production of fibroblast growth factor. And overall, the morphological analysis, as I was showing you here, indicated that laser therapy has the capacity to reduce the migration of white blood cells to the damaged nerve, leading to the decrease in edema areas and more rapid repair. Okay, next, how does it help on with respect to cartilage damage? So this particular experiment, by the way, there's lots of experiments. I'm just showing you the highlights here. Looked at osteoarthritis in a rabbit model. They excised the anterior cruciate ligament, let it degenerate on the medial femoral condyles, and this, of course, led to cartilage deterioration. So they started to treat with laser, and after about 2 to 4 weeks, there wasn't a lot of changes. And the reason for that, as we're all aware, chondrocytes take a long time to grow and repair. However, after 6 and 8 weeks, they observed significantly lower cartilage damage compared to the control group. So their findings were suggestive that laser therapy has a time-dependent effect such that it can help relieve pain and control inflammation, and it can help repair. And they're recommending that when you're treating things like cartilage degeneration, you need a long-term treatment, 6, 8 weeks, even longer. So this is important clinically because what we want to do is, if we're seeing these patients, lay out a treatment plan of at least 2 to 4 months to really have an impact. If you're only treating them for a few weeks, unfortunately, you just won't have the impact that you're looking for. Now, its effect on bone is really interesting. We do treat some fractures here in the clinic. Of course, you have to get the light to the fracture area. What we're trying to do is make sure that there's not a non-union or delayed union in the fracture area. And what light therapy can do is increase the synthesis, obviously, of DNA and RNA and the cell cycle regulatory proteins, and help promote specifically osteocyte and osteoblast and osteocyte proliferation. So in bone tissue specifically, it can help upregulate growth factors, different proteins and genes, specifically with respect to bone cell differentiation. This will lead to osteoblast proliferation and activity. So specifically, it's going to have an earlier recruitment of inflammatory cells, as well as a higher granulation tissue, and this can lead to a quicker callus formation at the site of the fracture. So really what we're trying to do is stimulate the osteoprogenitor or stem cells, turn them into osteoblasts, and repair this injured area. Again, you have to get the light to the area. So these are small fractures without a cast. If you have a cast, you're not really able to do this. Okay, now with respect to dosaging, this is an important factor. And as an intro lecture, basically what I want to do is just talk a bit about dosaging. So we talk about dose, it's in joules. So it's watts times time in seconds. And then, of course, if we hold it for a certain period of time, we're going to get dosage per point. We also need to take into consideration the surface area or the spot size of the laser or the LEDs. This will lead to energy density or power density dosaging calculations. So when you look at a research paper, you will see stuff like this: wavelength, the frequency, the power, the spot size, the energy density, the overall number of points used, total energy delivered. This is why, if you want to understand laser therapy, you need to have some fundamentals of what it is you're trying to achieve and what it all means, right? And the purpose of me speaking today is not to get into too much of that. Now, when we talk about pulsing the light, it's interesting that remember I mentioned Andre Mester. Well, his 2 sons have continued on to do some research, and Adam Mester, one of his sons, has looked into pulsing. And really what they've concluded is that when you pulse the light, you can tune the mitochondria of the different cell types to be stimulated more efficiently. So muscle cell compared to bone cell compared to a neuron, they all, of course, have different metabolic rates. And therefore, if we pulse the light at different frequencies, we may in fact be able to achieve a greater effect. Now, this is all very much, being researched and experimented, but Mester concludes by saying that once we know these parameters and understanding how to pulse the light and how to have dark periods and light periods when you're pulsing the light, then we can actually account for the specific energy demand of these cells and be more effective for treatment. Another thing I want to talk a bit about are the systemic effects. So when we talk about systemic effects, that's about treating an area around the tissue damaged area, so the bone marrow or the blood, and this can stimulate the stem cells and the white blood cells, and that will be carried in the blood around the general area of the damaged cells and the tissues to help actually promote healing as well. So remember earlier I mentioned about Andre Mester and his experiment, and he showed that even the adjacent wound was healing faster. Well, that was a systemic effect that I'm referring to. So quite a few research papers, one in particular, they compared spontaneous healing with respect to a wound that was healed with laser. So here are the same two wounds, same time frame, but you can see the one that was irradiated had a much quicker, faster rate of healing than the non-laser wound. Okay. So overall, it's been found that both red and near-infrared lasers can help produce repair of skin wounds by having a systemic effect by treating around the generalized area. Another way that laser therapy can help with pain specifically is endorphin release. We all are familiar with endorphins and understand how that works. Specifically, if we're talking about, say, myofascial trigger points, for example, they found that when you use higher fluences of energy, say in this case 27 joules per centimeter squared compared to 4.5 joules of energy, overall, they actually found that there was a greater amount of beta endorphins released in the blood compared to the lower energy. So the moral of the story here is that if you want to block pain, you want to have lots more energy, right? That's going to release actually more endorphins into the body than lower energy levels. Other ways that it can help with pain relief is decreasing things like substance P, bradykinin. I talked about prostaglandin levels as well too. And what's really fascinating is it can disrupt the flow of fast oxonal transport in pain nerve fibers like C fibers and beta fibers as well. So really what they found here is that if you use high power, high energy densities, you can actually exhibit an inhibitory effect on the A delta fibers and C pain fibers. So by blocking these pain fibers, you can slow the conduction velocity, and that leads to actually reduced pain sensation or an analgesic effect. A lot of this work was done by Roberta Chow, and she actually did research and showed that you get this formation of varicosities with this light, and it blocks the blood, blocks the actual flow of mitochondria, and it's reversible, and the effect can last up to 48 hours. This is a little video of showing you the normal flow of the axons of the mitochondria. And what she found is that when you expose it to high amounts of 830 nanometers of light, you get these formations of these varicosities, and it actually blocks the flow of these specific mitochondria. I'm running out of time. Boy, I guess I had a lot of information here. So this is just another couple of slides showing you, I don't know if you can see it here or not, these little vesicles. And this was just showing you these vesicles and how they form when exposure to the light. and that's the blocking of the axons. Okay, lastly, I'm going to talk a bit about biphasic dose response. And essentially all this means is that if you underdose light, you will have little or no effect. If you overdose light, you will have little or no effect. I'm talking about photobiomodulation, not about pain relief. However, an optimal dose will have a positive effect on healing. So really, we refer to this as the biphasic dose response, where if you have too little light, you have no effect. And between B and D, you have an optimal amount of light and therefore an optimal photobiomodulation effect. And then if you have excessive light, then you actually have a decreasing photobiomodulation effect. All right, wow, that was a lot to squeeze in. Just so everyone's aware, I am doing a entire full day training next Friday between 9 a.m. and 4:30 p.m. It's $199, and that is a whole day live event. If you want to join us, go to bioflexlaser.com, find events, and you can join us. Or in December, Friday 11th, also having another class, 9 a.m. to 4:30 p.m. Not next week, but the week after, November 26th, I have another webinar. This one is specifically on the BioFlex personal therapy system, on maintenance treatment for chronic conditions. Clinicians are also welcome to join us. It's designed for the general public that have our equipment or interested in it, but also clinicians may also find it beneficial as well. All right, so let's take a look at any questions. Okay, just so everyone's aware, I have this webinar recorded and I will release the webinar and all the details to watch it again in an email within a few days or into next week, so you can watch it again. I want to thank everyone for joining. I do have a question here about spider veins. I don't think it's really going to be helpful for spider veins because I believe that's more of a mechanical issue with the vascularity. So I don't think it's going to really do much to help spider veins, although I might need to research that. All right. Anyway, thanks everyone for listening in. I appreciate everyone joining in. Take care, and hopefully we can meet up again soon. Take care.